Thanks to everybody for joining us this evening. I'm Dr. James Elliott. I'm a nephrologist with Indiana Kidney Specialists. We are the Central Indiana region of NANI, which is Nephrology Associates of Northern Illinois and Indiana. And tonight I'm going to be talking about screening and treatment of chronic kidney disease in the somewhat new era where we actually have some pharmacologic agents available to us that were not available in the past. All right, I'm hoping that this is going to be a fairly brief, kind of high-level overview of the importance of screening for chronic kidney disease, as well as will help primary care physicians in the audience figure out when a good time to refer to nephrology is. And then I'm going to briefly summarize some of the guidelines as well as some of the studies that have kind of come along recently, looking at some of the newer pharmacologic agents that we have to help treat this. I think many of us are aware, kidney disease is a very big problem across the world and in this country. I'm not sure everyone's quite fully aware how big of an issue it is. 37 million patients in the United States are diagnosed with chronic kidney disease. That's 1 in 7 US adults. We can see from the data on the right that in the 1990s, incidence started to taper off a little bit, probably with the advent of ACE inhibitors, as well as an emphasis on blood pressure control. However, prevalence has continued to climb at a fairly steady rate despite this. And I think that's largely due to the fact that we are doing a better job keeping patients alive even once they end up with end-stage kidney disease on dialysis. So this particular study was looking at where the incidence and prevalence of end-stage kidney disease may end up by the year 2030. And the estimation is that by that time, we may be looking at 1.2 million patients with end-stage kidney disease on dialysis, burdening the U.S. healthcare system, the Medicare system. So I think many of us think of this progression to end-stage kidney disease as, one of the worst outcomes we're trying to avoid in these patients. However, I think that misses the point to some extent, and that is that chronic kidney disease has a very strong association also with mortality. This is data from the UK Prospective Diabetes Study. It looked at patients with diabetes and compared their outcomes when they had various degrees of kidney disease as well. On the left, we see the association between estimated GFR and mortality. And we see that as estimated GFR declines, we get an increase in both all-cause mortality as well as cardiovascular mortality that really begins at about an estimated GFR of 60 and continues to worsen as renal function declines. More notably to me is this chart on the right. This is really looking at the presence of albuminuria. And we see a very similar trend with albuminuria as we see with estimated GFR. So as albuminuria worsens, all-cause and cardiovascular mortality tend to increase. And if you'll note, this actually begins to become apparent at quote-unquote normal levels of albuminuria. By the time you get to severe proteinuria, with an albumin creatinine ratio of 1,000, our hazard ratio for mortality is actually approaching that of patients with stage 5 chronic kidney disease. I think this slide summarizes that well. This is from the same study with the UK Prospective Diabetes Study. And what we see is that patients with diabetes but no nephropathy have an annual mortality of about 1.4% This doubles to 3% with the addition of microalbuminuria. And you'll note that patients with microalbuminuria are equally likely to die every year as they are to progress on to macroalbuminuria. In those patients who do progress on, their risk of death is now double their risk of progressive kidney disease. By the time you have developed frank chronic kidney disease with low estimated GFR or dialysis, you can have mortality rates as high as 19.2%. So for me, I think really the take-home point here is that albuminuria, with or without impaired GFR, really affects mortality and progression of their kidney disease. And it becomes very important to screen for this, knowing that we now have agents that can help counteract that risk. So the question becomes, who do we screen? Obviously, you're not going to screen every patient that presents to your primary care office, but the KDIGO work group has come up with guidelines on their most recent release, referring to it in 2012, that can kind of help us with this. What they recommend is that all patients have assessment of the risk for developing CKD using measurements of blood pressure, as well as albuminuria and serum creatinine to estimate GFR among those patients who are deemed higher risk, which begs the question, what constitutes higher risk? On the right, there is a list of most of the factors that would be considered a high risk. I'm not going to go through these line by line, but what I do want to point out is, one, there are a lot of situations that increase a patient's risk for development of chronic kidney disease. And this list includes both diabetes and hypertension, as well as a history of acute kidney failure in the past. It also includes some demographic factors such as older age, minority status, as well as low income and education level. So in your patients who you're seeing who have one or more of these factors, I think it becomes a very good idea to screen these patients, not just with a basic metabolic panel, but also with a urine albumin assessment. Despite these recommendations, we see that in the United States, there's a fairly wide gap in identifying these patients. So this is data from the U.S. Renal Data System, annual report from 2022. And in a nutshell, what it's showing here is that even in patients with known chronic kidney disease, known diabetes, and known hypertension in the far column, only about 55% of those patients also had a urine protein assessment. When you look at patients without known chronic kidney disease on the left side of the graph, we see that that drops precipitously. So in patients with known diabetes and known hypertension, we are achieving less than a 50% rate of screening these patients for albuminuria. And in non-diabetics with hypertension, that falls precipitously to less than 10% of patients actually getting screened with a urine albumin assessment. I think the next question that often comes to a primary care provider's mind is, when can they handle and manage these patients, and when do they need the expertise from a nephrologist to help? On the right side of this slide, we've got the risk heat map, which is put out by the KDIGO group. And as you can see, any patient with macroproteinuria really warrants a nephrology referral. Any patient with an estimated GFR under 30, which puts them at stage 4 or stage 5 kidney disease, likewise warrants a nephrology referral to help manage. My own opinion is that these patients in the middle with microalbuminuria and stage 3 kidney disease I think an argument can be made that if you have nephrology referral sources available, uh, it would not be a bad idea, even in these more mild cases, to have a nephrologist input. Beyond that, of course, there's plenty of other reasons to send patients to the nephrologist, including abrupt change in the kidney function, any evidence of a glomerulonephritis going on, patients with refractory hypertension, etc. But in terms of chronic kidney disease, I think really the things to pay attention to are going to be the degree of albuminuria, as well as the level of GFR reduction. Similarly to screening, we see a pretty wide gap in practices. This again is taken from the 2022 USRDS annual report and is looking at data from 2019 and 2020. Most notable to me are these patients with stage 4 kidney disease in the middle. We know that really anybody with stage 4 disease has a chance of preventing or slowing progression and would benefit from referral to a nephrologist. And yet we're only seeing that about 50 to 60% of those patients actually receive nephrology care. It's actually remarkable to me that patients with stage 5 kidney disease have an even lower rate of nephrology referral, although I suspect that in many of those cases, comorbidities and goals of care likely come into play as well. So this is data which was conducted as a meta-analysis looking at studies that have compared early versus late nephrology referral. What we found is that beyond the subjective benefits, which include better preparation for dialysis, better preparation and dialysis access placement, more options in terms of choosing home dialysis modalities, there are also some very concrete benefits to having patients followed by a nephrologist. We see that overall mortality in patients who were referred early is substantially lower than those patients who are referred later. So overall mortality was 11% in those patients referred early versus 25% in those patients referred later. Some of that is going to, of course, be lead time bias. However, I think there's a very real effect in terms of the nephrologist's ability to help care for these patients and minimize their risk. We see that same benefit when we look at hospital length of stay, and that patients who are being followed by a nephrologist earlier have fewer hospital days. So what are the goals when you find these patients with evidence of chronic kidney disease, whether that's through a low GFR or whether that's through the presence of albuminuria? What should our goals be in managing these patients? And I think first and foremost, we want to make sure that we are excluding any reversible etiologies, such as a glomerulonephritis. We don't want to assume that a patient has diabetic or hypertensive kidney disease and miss the fact that, in reality, they may have had IgA nephropathy or another progressive disease that could have been treated differently. Once we establish that this is indeed chronic disease due to their underlying comorbidities, I think we really focus on delaying progression of that kidney disease, but we also want to minimize their risk for cardiovascular morbidity and mortality. And those patients who nevertheless progress on, we then have a switch in focus to educate and prepare those patients not only for dialysis and dialysis access placement, but also for early referral for kidney transplant evaluation in those patients who may be a candidate. So for years, we've had the same general measures that we've focused on, right? That involves getting rid of nephrotoxic medications, the most common of which we encounter, I think, are the nonsteroidal anti-inflammatories, but also minimizing exposure to IV contrast when we can. We know in our diabetics that we want to keep their hemoglobin A1C level under 7 if possible to halt that progression of further diabetic damage. Our smokers really need to be counseled to get off the cigarettes. Cigarette smoke is the foot on the gas pedal for a lot of diseases in the body, and that includes chronic kidney disease and cardiovascular disease. Because of that increased risk for cardiovascular disease, most of our older patients should also be on a statin. And any of our younger patients under 50 who have other known cardiovascular risk factors also should be on a statin. We know that certain dietary modification can also help improve renal outcomes. Notably, protein intake is recommended to stay at a moderate level. So as roughly 0.8 grams per kilogram of body weight per day would be the recommended protein intake for these patients, as well as a sodium intake below 2 grams per day. And we should be counseling these patients on weight loss to maintain their BMI in the 20 to 25 range. Finally, blood pressure control, we know, is an extremely important part of slowing progression. The most recent KDIGO guidelines use data from the SPRINT trial and now recommend a target blood pressure of 120/70 by standardized office measurement. The biggest problem with that recommendation, of course, is achieving a standardized office measurement, which essentially entails the patient coming in 5 to 10 minutes early, sitting in a quiet room, and then having their blood pressure checked in a standard fashion 3 consecutive times with 2 minutes in between each check. That's very hard to do from a practical standpoint in the busy outpatient office. And so a reasonable alternative, I think, and this is my opinion, this is not part of the guidelines, but I think a reasonable alternative is a home blood pressure running less than 130/80. So beyond those general measures, we now have a total of 3 pharmacologic interventions that can be considered and have been proven to delay that progression, not just of renal disease, but also for cardiovascular disease, which these patients are at such a high risk of. The oldest of these, of course, are the RAS inhibitors, right? ACE inhibitors and angiotensin receptor blockers. The SGLT2 inhibitors are one of the newer medications that have come online just within the past few years that have been shown to be beneficial. And we now also have, for diabetic nephropathy, the nonsteroidal selective mineralocorticoid antagonist, finerenone. And I will review some of the trials that have led to widespread use of these. So really the first medication to come online that was shown to be beneficial was captopril. And this was all the way back in 1993 with the captopril trial. It was a small study of only 409 participants. All of them had diabetic nephropathy as defined by a proteinuria level of greater than 500 per day. All of these patients had chronic kidney disease with a creatinine reading less than 2.5, so this was moderate disease, not severe disease. And they were followed for an average of 2.7 years. Patients were randomized to receive either captopril or placebo, and a composite endpoint of death, dialysis, or transplantation was evaluated. On the right, we see the Kaplan-Meier curves, and essentially what they're showing us here is that we have a relative risk reduction of about 50% in that composite endpoint, and we have a 48% relative risk reduction of doubling of serum creatinine over the 2.7 years of the trial. I think what's notable in this is that even with this improvement, the composite endpoint was still reached in about 12% of participants in the study arm. So captopril does help, but does not solve the problem for us. I think this benefit extended beyond ACE inhibitors to angiotensin receptor blockers really in 2001, 2002 with the Referral trial. Again, a little bigger study looking at losartan use. It also was in patients with diabetes only who had advanced kidney disease. It enrolled 1,500 patients with proteinuria and a creatinine between 1.3 and 3.0. And again, median follow-up here was 3.4 years. These patients were also randomized to either losartan or placebo. And they looked at a composite endpoint of doubling of serum creatinine, development of end-stage kidney disease, or death, and found that there was a relative risk reduction of about 16% in this composite endpoint. I think notably in this trial, there was no significant difference in their secondary endpoint of cardiovascular morbidity and mortality. Now, we do have other studies that have come out to show benefit in the cardiovascular setting of angiotensin receptor blockers, but it was not as striking, certainly in this trial. And again, despite this improvement, those patients on losartan still reached that composite endpoint in 43.5% of the cases by study's end. So I think that brings us to our newer agents, which in the nephrology world, I think we're all very excited about because finally, for the first time in 20 years, we have new tools which we can use to really mitigate some of these risks. In 2021, the DAPA-CKD trial was published. This was a large study, looked at over 4,300 patients, and for the first time using the SGLT2 inhibitors, we looked at both diabetics and non-diabetics to look at what is the benefit on their renal outcomes as well as their cardiovascular outcomes. Patients to be enrolled had to already be on the maximum tolerated dose of an ACE inhibitor or an ARB. They could be a diabetic, but they didn't have to be. So there were non-diabetics enrolled in this trial as well. And they were followed for an average of 2.4 years. Once enrolled in the trial, patients were randomized to receive either 10 milligrams of dapagliflozin or placebo. And what we found is a 39% relative risk reduction in the composite primary endpoint of sustained loss of GFR greater than 50%, development of end-stage kidney disease, or death from a renal or cardiovascular cause. DAPA-CKD also had several secondary endpoints that they looked at, essentially dividing the renal outcomes out from the cardiovascular outcomes. And we see that both in the case of the composite renal outcome, as well as composite cardiovascular outcomes, which includes cardiovascular events as well as hospitalization for heart failure, we see substantial improvement in relative risk. Excuse me. Such that there is a 44% relative risk reduction in development of end-stage kidney disease or sustained loss of GFR or renal death, and a 29% relative risk reduction in the composite cardiovascular outcome. The study also looked at all-cause mortality and found that at the end of the study, there was a 31% relative risk reduction for all-cause mortality. One thing to note on the Kaplan-Meier curves that we see in here is just how early these outcomes begin to diverge. So we can see that as early as 4 months, we begin to see divergence between the study arm and the placebo arm for renal outcomes, and as early really as 2 weeks for the cardiovascular outcomes. So I think this trial really shows that there is strong evidence of benefit, both from a renal standpoint and cardiovascular standpoint, and that this benefit begins very early after getting our patients on these medications. Not to be outdone, the EMPA-KIDNEY trial came out looking at empagliflozin just last year, I believe in October or November last year, if I'm remembering correctly. Likewise, this was a large study. It had over 6,600 participants. Its inclusion criteria were a little different than DAPA-CKD. And there were essentially 2 ways that you could be included in this trial. Either you could have a reduced GFR in the 45 to 90 range with albumin creatinine ratio of at least 200, or you could have a more significant decrease in estimated GFR, irrespective of the albuminuria. Similarly to the DAPA-CKD trial, we see that the patients treated with empagliflozin had a 28% relative risk reduction in their composite endpoint, which included a 40% sustained decline in GFR, development of end-stage kidney disease, or death from a renal or cardiovascular cause. I will note that this composite endpoint is slightly different than the definitions used in the dapagliflozin trial. And I will also point out that this study included patients with potentially milder disease, and that they did not have to have any degree of proteinuria to be enrolled in the study. Both medications, not surprising since they are in the same family, have a similar effect on a patient's estimated GFR. And most notable is this dip that we get immediately after putting a patient on these medications. So both dapagliflozin and empagliflozin cause an immediate drop in estimated GFR. But we can see that as we go out in time, the benefit of being on the medication quickly begins to outweigh this initial decline. So that at about a year out on dapagliflozin and at about 18 months on empagliflozin, we see that a patient's estimated GFR is better off to have been on the medication. Adverse events across the category or across the family of medicines is similar. And most notably, we need to watch out for genital yeast infections. This is more prevalent in females, but also occurs in males. There is also a very slight risk of increased incidence of urinary tract infections. This impact is actually pretty small, particularly in non-diabetics, and is in the about 1% range. These medications do have a diuretic effect, so hypovolemia is a consideration, as is diabetic ketoacidosis in any diabetic taking the medicine. These medicines are contraindicated in type 1 diabetics for this reason. However, even type 2 diabetics are at an increased risk for DKA, particularly if there's any circumstance in which they cannot take in food. So these medicines really should be held if a patient is vomiting or if they are NPO for surgery. Beyond that, there are some more minor possibilities for adverse events. Some patients did complain of polyuria and dysuria, and there is in diabetics a slight increased risk of hypoglycemia in any patient taking a sulfonylurea or on insulin. So practical considerations when prescribing these medications. So first, this is not a titrated medication when you're using it for this indication. One dose fits all. So all patients are started on 10 milligrams every day. No dose titration is needed. Because of that risk of hypovolemia, I think any patient on a loop diuretic, you should consider decreasing the dose of that diuretic or even holding it if they don't absolutely need it for a period of time. Likewise, any diabetic who's on a secretagogue or on insulin, I think you should consider reducing the dose of those medications while you start. The risk for genital yeast infection or UTI are probably the most prevalent risks to the patient. And so I think all patients need to be counseled that this is a possibility, and they need to be sure to alert the physician if they notice any signs of these happening. Beyond that, all patients really need another basic metabolic profile checked about 4 weeks after starting the medication. This can exclude the development of an anion gap from DKA, and also can exclude acute kidney injury from hypovolemia. Keep in mind, however, that we do expect some drop in kidney function. So as long as you get a reasonable drop, my rule of thumb is less than 30% increase in creatinine, then I think it's okay to continue the medication and monitor. Anything more than that, you really need to look at other etiologies for acute kidney injury, including hypovolemia, and may have to back off of the medication. So that's it for the SGLT2 inhibitors, and brings us to our third and final medication, which is finerenone. This medication is a novel agent that was proven, again, beneficial for both renal outcomes as well as cardiovascular outcomes in the complementary randomized controlled trials of Figaro DKD and Fidelio DKD. These trials were conducted simultaneously. They were intended to complement each other and looked at what they call reciprocal endpoints of cardiovascular outcomes and renal outcomes, specifically in diabetics with nephropathy. Between these two trials, there were over 13,000 diabetic patients enrolled, and were then randomized to receive either finerenone or placebo. Similarly to the SGLT2 inhibitor trials, all patients had to be already on the maximum tolerated dose of their RAS inhibitor. And they also had to have a potassium level less than or equal to 4.8 before they could be enrolled. Finally, it's notable that any patient with known heart failure and reduced ejection fraction were excluded from this trial because we already know that those patients should be on a mineralocorticoid receptor antagonist such as eplerenone or spironolactone already. Similarly to the EMPA kidney trial, there were two inclusion groups, those with microalbuminuria and a GFR between 25 and 90, or those with fairly normal GFR, but macroalbuminuria. Notably, patients without any proteinuria were not included in this trial. What they found is an 18% relative risk reduction for their composite renal endpoint, which we can see the components over here in the Kaplan-Meier curves on the right. In addition to this, we see a 31% reduction in albuminuria at month 4. When looking at the cardiovascular endpoints of cardiovascular death, non-fatal myocardial infarction, hospitalization for heart failure, or non-fatal stroke, we see that finerenone reduced the relative risk by 13%. Notably, they were able to tease out that the presence or absence of known previous history of cardiovascular disease did not affect these outcomes, and benefits were seen with or without known cardiovascular disease being present. Main safety considerations for finerenone. This is a mineralocorticoid receptor antagonist, so similar to medications like spironolactone, these patients can be at risk for hyperkalemia. They also can be at risk for hypotension, although, as you can see, there's a fairly small incidence of hypotension in the conducted trials. Hyperkalemia was more significant. It occurred in 14% of patients in the study arm versus only 6.9% of patients in the placebo arm. Hypotension, a slight increase from 3.9% in placebo up to 4.6% of those in the study arm. Hyponatremia also had a statistically significant increase. However, you can see from the numbers that it's a very small increase in risk. I think it's also notable that there is an interaction between finerenone and CYP3A4 inhibitors. So this needs to be taken into account when prescribing the medication. Again, when prescribing finerenone, there's some practical considerations. First, this study was conducted in diabetic nephropathy. It was not inclusive of any other type of kidney disease. So patients with a different etiology that is known, or patients without diabetes, should not be put on this medication. Again, as mentioned, any patient with reduced ejection fraction should probably be on a steroidal MRA, such as eplerenone or spironolactone, rather than the finerenone. Also, if a patient's potassium is 5 or greater, they should not be started on this. And if their potassium is between 4.8 and 5, they really should be monitored closely for development of worsening hyperkalemia. The starting dose that we use for finerenone differs based on a patient's estimated GFR. So patients with normal potassium and normal GFR can be started at the full recommended dose of 20 milligrams per day. But those patients who have reduced kidney function, who are the majority of patients that we see in the nephrology clinic, they're going to start at half of that. So 10 milligrams per day for any patient whose estimated GFR is below 60. And remember that patients with a GFR under 25 were excluded from this trial, and so should not be started on this medication. It's important to check a serum potassium about 4 weeks after starting this medication, and I would argue that if they're in that 4.8 to 5.0 range on potassium previously, we probably should be checking a potassium within 1 to 2 weeks. If a patient's potassium remains less than 4.9 after starting them on the 10 milligrams, we can then go ahead and increase it further to 20 milligrams. If they fall between the 4.9 and 5.5 range for potassium, we maintain on the current dose of 10 milligrams per day. And if their potassium has jumped higher than 5.5, we need to hold finerenone and would only consider restarting it once a repeat potassium has come back down to normal. So in conclusion, again, I think the points I've tried to make, and hopefully were clear, is number one, it's very important to have a high level of awareness and suspicion for those patients who are at high risk of chronic kidney disease. And part of that screening and detection of these patients should include checking an albumin-creatinine ratio to detect those patients who have not yet developed impaired estimated GFR. For those patients who have macroalbuminuria greater than 300 milligrams per gram, or have an estimated GFR that puts them at the stage 4 or 5 kidney disease range, that should prompt an automatic referral to nephrology. I would also consider any patient with stage 3B kidney disease with microalbuminuria as somebody who could potentially benefit from a nephrology evaluation. In terms of general measures, I think tight control of diabetes and hypertension are very important to delay progression of cardiovascular and renal disease, and that's been known for quite some time. Again, our goal blood pressure target now is very strict, with a target of 120/70 based on office readings, standardized office readings, or in my opinion, a home blood pressure trend less than 130/80. Remember that any patient with proteinuric CKD would benefit at this point from being on both a RAS inhibitor and an SGLT2 inhibitor. For those patients whose kidney disease is being caused by diabetic nephropathy, I think we also need to consider, in addition to these two medications, adding finerenone. Again, starting at a dose of 10 milligrams per day for those with reduced GFR, and eventually titrating to 20 milligrams per day.